So the thick skin is not exclusive of any ethnic group. So you can see in every race. However, it's more predominant in the non-Indo-European races. Most of the people who live in Europe and United States and many that migrated to Central and South America comes from the Indo-European area, from the Caucasus originally. That's where we think that the white people comes from. The thick nose can happen in white races as well. However, it's more predominant in the non-Indo-European races. And which are these races? The rest of the races in the world. So you see in Hispano-Americans, blacks, Mediterraneans, Middle Easterners, Orientals. The problem is excessive thickness of skin that eliminates the angularity and nasal aesthetic definition, lack of faceting or geometric planes, increases the size and volume of the nose, particularly at the tip and the base of the nose. This is associated with a small or normal osteocartilaginous vault. There's a majority of these patients, they have a minimal tip support, short medial crura, weak caudal septum, short hidden columella, broad alar base, and round nostrils. This is one patient, although doesn't have much of these characteristics, but she has a very thick skin that became more manifest after she had several surgeries, and this thickness mostly was scar tissue. So this is before her first surgery, this is after her first surgery, this is after her secondary surgery or tertiary surgeries. She had like 3 or 4 surgeries before. And obviously she compares against her friend who has a nice thin skin, and she wants to improve the nasal appearance. And this is the way how she came to me. She has inverted V deformity, thick nose, thick tip, and acute nasolabial angle, columellar nasolabial angle, and droopy hanging columella, etc. So many of these patients, if I have the time, this patient was done in another country, so I didn't have the time to pre-treat her. But many of these patients, I do a skin conditioning program, but the skin conditioning only goes to the superficial layers of the skin, doesn't go deep. However, I use Accutane or Roaccutane in a low dosage. It's about 10 to 20 milligrams a day for 1 week, 10 to 20 milligrams every other day for another week. And maybe then I start going down twice a week for 2 weeks. So I'll pre-treat them for about a month before the surgery. So that diminishes the sebaceous glands of the nose. Because a lot of these patients, they have thick sebaceous glands. And as I mentioned in the morning, these patients, they have high concentration of fibroblast in that layer of sebaceous glands. So, and that when you do surgery, you stimulate the fibroblast, and it's going to stimulate the scarring. So the idea was to quiescent, to make it less reactive. These sebaceous glands reach in scar-forming tissues, fibroblast, and then and also because after the surgery, they might continue creating scarring for about 3 months. So I put it on low dose, 20 milligrams twice a week. So this small dose is enough to control the sebaceous glands activity. Then I could do the surgery, And this patient, she did not get the Accutane. So what's the strategy when you have this? You have to use a lot of grafting to stretch the skin. Otherwise, you won't have any definition at all. So this patient had a dorsal graft, tip graft, alar graft, columella graft. So you need to expand the skin to be able to give the illusion that at least the skin is thinner. So here is the columella graft. No. So this is the, sorry, the movie is not working. So this is the columella graft. This is the tip graft, very long, in front of the, remember, she got a very acute angle. So I needed to bring the whole columella out, and I put it as columella graft, and on top of that, I put a large tip graft. So in addition to that, and then alar graft. So this is the alar, this is the tip. In addition to that, I dice the cartilage. Why is it not working? Anyway, so you dice it, in a small particles, and you put it in a syringe, and then you fill them up in the tube of fascia. And this diced cartilage was obtained from the septum because I needed a lot of material to use for this structural support. All the leftovers graft, I use it for the, sorry. I use it to do the dice. And this fascia is from the rectus sheath. So some people, they go back to they get the graft from here and go to the temporal. It's another incision, another surgery. So it doesn't make any sense. You can just get a piece of the fascia from the rectus. So in general, the strategy is to do minimal hump resection, do dorsal augmentation, Nasion augmentation, low-to-low osteotomies, because this patient, generally, they don't have a big bone, so you need a lot of bone to be able to advance it medially. If you do low to high, you end up with a small bone, and there's nothing you're going to advance medially. You might end up also with a step deformity. I use a percutaneous osteotomy and a green stick fracture, a strong columellar support for the nasolabial angle, triangular shaped graft for the columella, and I put it in between the medial crura. I use a lateral crural rotation to prevent notching, or if the lateral cartilage still is available. Because since they have thick skin, I prefer not to put an alar graft because I make it thicker. However, many of these patients, they don't have any alar, it's everything just scar tissue. So I need to provide support with a cartilage graft. For the nasal tip, I resect the fat between the domes, crural sutures, like I mentioned, to increase the support. Anyway, so for the nasal tip, I do, because the skin is so thick, and there's a scar, despite I remove the scar, so the tip of these patients, they have their own memory. Despite that you put any graft, the tip doesn't move anywhere. So I do scoring of the subdermal layer and their loop magnification with the blunt scissors. And the reason is I don't want to perforate it, so with the blunt scissors, I try to break the subdermal layer. That way I don't damage the blood supply. In that way, I stretch it. It's like scoring the gallia, similar concept. So I score it, the subdermal layer, to allow the skin to stretch. And then I use very angular tips, tip graft, with a lot of angles, so to be able to provide that defining points. And in the base of the triangle, because the chin graft on the upper portion is floating, and if you have very thick skin, then that graft can bend. So I put another piece of graft to support it like this. So this is supported on the septum, and the graft is like that. If I leave it free like that, the graft can move with a thick skin. So this is the double layer thickness at the base of the triangle shin graft. Wedge resection, with or without seal, depending on the situation. So this is just some of the maneuvers: hump removal, spread the graft, columella graft, tip graft, wedges. So this is the standard extramucopericardial dissection. If they have a septum, I get it from the septum. And this is how I distributed the different components of the grafting. So tip graft, columellar, spreader graft. So this is the scoring of the subdermal layer. And after the surgery, I use about 1 or 2 weeks after the surgery, while still you have some space, because if you wait longer, everything is fused, and if you put any canalog injection, it might go to different area where you don't want it. So while still there's some space and the scar tissue is not too hard, you can inject diluted canalog to the supratip area to prevent scarring. So on those patients routinely I use that, very diluted, about 3 to 5 milligrams of canalog, maybe in 1 cc, and injected that. And as I mentioned, I continue with Accutane for about 2-3 months. So this is a patient with a boxy tip, very thick skin. She has acne. You'll see that this patient, this patient, I did the scoring, looks a little bruised, but the vascularity is fine. It just is the bruising from the maneuvers. So this is she has very small nasal bones. Everything is cartilage and soft tissue, thick skin. So the definition is better. She has more balance. This is a closed rhinoplasty, and the nasal tip is better. Lobule columellar proportions are good. This is another patient, small nasal bone, thick skin, boxy cartilage. And again, I did the same. So now she is more in proportion, the dorsum and the tip. Columella, I had the impression that the tip is thinner. The boxy appearance has improved. This is another patient, Mediterranean origin, very thick skin, almost rhinophyma. And I did a closed rhinoplasty with septal graft for the tip, columella, alar, and again I treated the tip. So now after that he looks like he has a thinner skin. Another patient with a very thick tip. So I did the same. So he's has a well-defined tip, maybe a little feminine perhaps, but he wanted very well-defined. And this patient came with extruded silicone implant. He's a Chinese. So I removed the implant, put it, in this case I use the block of rib graft for the dorsum, put a columella, alar tip. So I expanded, and this is still very early, maybe perhaps a little visible border of the graft. So I saw him a little later, he looks better, the dorsum, the tip. So this is another patient in which I did these maneuvers, sliding genioplasty, wedges, defatting, and I put a spreader graft, tip graft, alar supporting graft, because sometimes the spreader graft might not be enough in some of the patients with the intermediate valve collapse, like in here. So very thick skin. So expand it, give the illusion that she has a thin skin, and I did a sliding genioplasty, so she looks more balanced. This was a closed rhinoplasty. Another patient with previous rhinoplasty, very thick skin. I expanded. Her nose looks smaller, but actually it's larger. I augmented the dorsum. The tip is longer, and the columella is more visible. So is a question? Yeah, there's another patient again with the same situation. I put it on her. This is the one I presented before. I put also the Medpro implant, but again I expanded. She's very thick. So you need to expand it and make it look the skin is thinner. You cannot do reduction in the thick noses. So if the patient has a big nose and is very thick, you have to do it in 2 stages perhaps. One is to reduce it the most that you can, still put support, and then tell him, might not be well defined, you have to come back to expand it with additional graft. So let the skin to contract, to well support this nose, and then come back, put an additional expansion graft. So this is another patient with a thick skin. So this is the grafts I have put it on him, columella, spreader graft, nasoglavella angle, and then also angle and chin implant. So whatever I call it, the mandibular matrix implant. So this is the nose. Also here a cheek implant. So angle, chin, cheek, and nose. So he looks more handsome. Another patient with previous rhinoplasty, a lot of scarring, thick skin. So this is more balancing. Her nose perhaps is overall maybe bigger, but the tip is smaller or thinner. The alar is thinner. Augmented the dorsum, and she looks more balanced. She's a very tall lady, so she has more definition. So I don't think, if the nose looks nicer, I don't think the patient mind to have it a little bit bigger. So this is a patient with rhinophyma, very thick. You'll see all the rhinophyma elements, acne. And I gave her Accutane. I did a small hump reduction and augmentation with grafting, columella, tip, spreader graft. I got it from the septum. This was a primary rhinoplasty. I do the scoring, wedges. So now she is better. There's no, because undoubtedly this patient, they're going to develop supratip deformity if you don't treat them the way that I mentioned. So this is a patient who I did she wanted some reduction of the nose, a little more definition. So I did it the first time. She was not happy. I brought her back and I reduced more. So this is after the second reduction, first reduction, second reduction, first reduction, second reduction, first reduction, second reduction, first reduction, first reduction, second reduction, first reduction, second reduction, first reduction, second reduction. She looks more balanced and more beautiful nose with some facets. So in conclusion, it's a high satisfaction rate of these patients if you handle properly. No many complications. Many patients will require secondary surgery for tip re-elevation. So you might need to put an extra tip if you don't see a good definition. Thank you very much. We still have time for another lecture, right?
Yeah, we still have some time. And may I ask you just one question? And do you feel that dermal abrasion could be helpful somehow in managing patients with a thick skin?
The what operation?
Dermal abrasion, CO2 laser resurfacing, or chemical peel.
Yeah, I have done some of them. You can, but the problem is whenever you do a laser, you open more the pores of the nose, so the pores becomes larger. Perhaps you can thin out the skin, but the pores becomes larger. So that's a problem I find it with the laser for the.
I see. So that is the other side of the medal.
If they have rhinoplasty, yes, probably it will help. But regularly for a patient with very large pores, the pores becomes worse with the laser.
Oh,
That's my experience.
And do you have any experience in direct excision of skin somewhere just above the nasal tip or in the dorsum?
No.
No, never.
No. I have done it in older patients on the dorsum of the nose to lift the nose. But I'll show you that's another way how I handle those droopy noses in older patients.